So last time, we spent most of our time, or the whole time, talking about connective tissue. So that was kind of the prelude to joints, and so we're going to get into joints in quite a bit more detail today. So I changed the wording on this first slide a little bit. So if you have the older version, where it says two means of classification, I think on the old one it says two classifications or something like that. I think this is a little bit more clear in the wording. So as mentioned, in terms of joints, so what those are the intersection of two or more bones, are joints or articulations. The two can be used synonymously. So in terms of the ways to classify joints, the first way is to classify them based on structure. So what do they look like, and what physical structures are there, right? So is there joint space? Is there not? Are there fibrous sheets that connect the two bones? Are there not? Are there cartilage plates that connect the two bones, or are there not, right? And so in a structural classification, we are describing a joint based on the structures that are present. So as far as structural classification goes, and that's actually how we're going to classify them for the rest of the slideshow, is structural classification. But the gist of it is, so if we're talking about fibrous joints, you've got two bones that fit together kind of like puzzle pieces. So there's a lot of interconnection between the two bones. And then there are really strong, broad ligaments that connect those two bones. In the case of cartilaginous joints, so you've got a cartilage plate of some kind that connects two bones, or two parts of the same bone in some cases. And then with synovial joints, you've got a joint space and a joint capsule. There are other things that are inherent to synovial joints, but those are kind of the big two. The other way to classify joints is based on their function. And so the function with a synarthrosis, you effectively get no movement, or that's our goal. We're trying not to get any movement between those bones. So synarthroses, no movement. Amphiarthroses, as you would expect, some movement. And then diarthroses are freely movable. And so an important thing to understand about that, so one of the things normally when this is taught as a one semester class, in the intro lecture I talk a lot about the interrelationship between structure and function. The way something is shaped or built determines what it does or what it can do. So as it applies to joints, the structure determines the function. So our fibrous joints up here are our synarthroses. So because you've got, in the case of a fibrous joint, because the two bones fit together kind of like puzzle pieces and they've got a lot of really strong ligaments between them, you get no movement between the bones, and that's kind of our goal. So fibrous joints are synarthroses, they don't move. Cartilaginous joints, again, two bones connected by cartilage, you get some movement. And so those are your amphiarthroses. At some of those you actually get no movement, but at a few of the cartilaginous joints you do get some movement. And then synovial joints, so because you've got a space between the two bones and a capsule, those are freely movable, and so those then are diarthrodial. So based on the structure, it tells you the function. So we're going to use the functional classification because that's what this anatomy textbook uses, which is fine. Usually, we're going to use the structural classification, because that's what this anatomy book uses. Typically, the functional classifications come in when you take biomechanics, because you're interested in what it is that the joint can do, what's the range of motion of that joint, how many degrees of freedom does it have, all that kind of stuff. So functional classifications are typically used more in kinesiology or biomechanics classes. All right, so as mentioned, fibrous joints, typically the two bones fit together like puzzle pieces, and so you see that primarily when I'm thinking about that, when I'm describing that, I'm primarily talking about between the bones of the skull. So we'll get to those near the end of the class, but for example, the interaction between the frontal bone that forms your forehead and then the parietal bones on either side that form kind of the superior lateral aspects of the skull, those are going to fit together really, really closely. And then you've got connective tissue that's going to adjoin those two bones. And as you'd expect, we don't really want movement at that joint. We don't need our skull bones moving around any. That could obviously be dangerous for us. So no movement is the goal there. Other things, so there is no joint cavity. The bones directly touch each other, so there's no space between them. And that's important to make sure that there's no movement. And as mentioned there, most of them are immovable. So sutures are what I was describing there. So the sutures are the bones between the skull. Syndesmoses, you've got two bones that touch each other directly. They're connected by a ligament, and sometimes they're also connected by a fibrous sheet of connective tissue, or fascia. So the syndesmosis that we'll spend most of our time talking about is the interaction between the tibia and the fibula and the lower leg. So in your lower leg, your primary bone of your lower leg is your tibia. It's the medial of the two. It's your shin bone. When people talk about their shin bone, they're talking about their tibia. And then the lateral one, the smaller of the two, is your fibula. And so what you're seeing on this picture, they're labeled good. So there's your tibia, there's your fibula. So you're looking at the right ankle from the front, and so you've got an anterior and a posterior inferior tibiofibular ligament. So that's the anterior inferior tibiofibular ligament that's on there. And then you also have, and it's not pictured, but there's a sheet of connective tissue here, an interosseous membrane. And we talked about the interosseous membrane in the forearm because there's a similar one that runs between the radius and the ulna. So that's a syndesmotic joint. The reason that matters, or the reason that might be of interest to you, if any of your football players in this fantasy football season get high ankle sprains, a high ankle sprain is an injury to this ligament, that anterior inferior tibiofibular ligament, and also to that syndesmotic membrane. You're stretching out the membrane every time they take a step, and it's incredibly painful. So it's a disruption of the syndesmosis if you get a high ankle sprain. The last one, gomphosis, it's a peg and a socket. The only example in the body is the teeth. They fit inside the socket, inside your maxilla or mandible, and then there's a ligament actually inside of the little socket that holds your teeth in there. Pretty small ligament, but there is one that holds them in there. So gomphosis, peg, and a socket. So fibrous joints, the most important thing I want you to know, they don't move, ideally. If they do, there's something wrong. So like after a high ankle sprain, you're going to get some movement in that inferior tibiofibular joint, but we don't want that. That's painful, and it's not optimal. So we don't want that. So typically, or what we want is no movement at our fibrous joints. Cartilaginous joints. So two bones joined by cartilage, or, as I'll show you in a second here, in some cases, the same bone joined by a plate of cartilage. So there is no joint cavity, as it says on there. So the two bones are directly touching the cartilage, and there's no space between the bone and the cartilage. Some of them are movable, some of them are not. And I'll get to that here in a second. So there's two types that you can see on there, synchondroses, and the key there is that a synchondrosis is formed by hyaline cartilage. And we talked some last time about the difference between hyaline cartilage and fibrocartilage. So with synchondroses, where they're going to become important for us is at the growth plates, or the more anatomical term for them, or more scientific term, is the epiphyseal plate, but the more colloquial term is the growth plates. So you see hyaline cartilage there at the growth plates. So this is the proximal growth plate of the humerus. And so I showed you a couple of those on an x-ray last time, or 2 times ago, when I talked about Little League elbow. And there was the growth plate in the distal humerus and the growth plate in the proximal aspect of the radius. So growth plates then, because they are hyaline cartilage, count as synchondroses. And obviously, ideally, we don't get any movement there. You don't want your growth plate shifting around. That's a fracture when that happens, so that's bad. The other example of a synchondrosis is the interaction between the ribs and the sternum. So your sternum is that bone in the middle of your chest. And so, as mentioned before, there's no direct bone-to-bone connection between your ribs and your sternum. There's cartilage that sits in between. And so that's hyaline cartilage. So the name for that specific one is called the costal cartilage. And then with symphyses, so symphyses are two bones joined by fibrocartilage. So it's much more dense. Typically, it's made to absorb shock with fibrocartilage, because we talked about fibrocartilage sometimes being inside of the joints, like the menisci of the knee. And so we see fibrocartilage between the intervertebral, between the vertebrae. So fibrocartilage makes up the intervertebral discs. So if you hurt your disc, you've damaged, to some extent, that outer ring of fibrocartilage that makes it up. You also have a ring of fibrocartilage between each side of your pelvis called the pubic symphysis. And so that's one where ideally we don't get movement, but there is some that occurs. So for example, if you really forcefully hyperflex or hyperextend your hip, you can get some twisting that occurs there at that joint. So for example, sometimes like punters in football, from having to really hyperextend and really hyperflex on their kicks, will have really deep groin pain. That could be any number of things, but some of the time, that is an irritation at that pubic symphysis from too much movement basically occurring there. All right, so then on to synovial joints. Oh, one last thing, just as a point of emphasis. So typically with synchondroses, we don't get and we don't want movement if there's hyaline cartilage there. With the symphyses, sometimes we do want movement, sometimes we don't. So at the pubic symphysis, we do want to allow for a little bit of movement, but just not much. In the case of the intervertebral discs, obviously we want to allow for quite a bit as you flex the spine, when you bend forward, extend, rotate, all that stuff. So we do want a decent amount of movement in the intervertebral discs. So we do get some movement with symphyses, and some of it's okay, but typically with synchondroses, we don't want movement. All right, now on to synovial joints. So as mentioned, the two biggest characteristics of synovial joints, joint cavity, so space between the bones, and then a joint capsule. So you have connective tissue that joins the two bones. And so because you've got a space and the two bones are connected by connective tissue, we get quite a bit of movement at our synovial joints. So the joints that we've talked about so far in this class, all the ones I can think of, so the sternoclavicular joint, the acromioclavicular joint, the glenohumeral, humeral ulnar, humeral radial, radial ulnar, all of those are synovial joints, right? So most of our joints where we get big osteokinematic motion, big readily observable motions, those are our synovial joints. So in terms of the characteristics of them, so they're going to have articular cartilage that lines either end, or that lines the ends of the long bones inside of the joint. So remember that articular cartilage is a special kind of hyaline cartilage. We talked about hyaline cartilage last time, that there are chondrocytes in there with quite a bit of extracellular matrix and a lot of type 2 collagen. Articular cartilage has two jobs that I mentioned last time. You remember what the two things articular cartilage is supposed to do are? Two things are cushion impact. So they basically protect the underlying bone. And so as mentioned last time, the thickness of that articular cartilage depends on the joint. If it's a joint that bears a lot of weight, so for example, the hip joint, that articular cartilage is as much as 7 millimeters thick, so it can be fairly thick cartilage. In the case of like in the fingers, it'll be much thinner, maybe 1 or 2 millimeters, right? So, but the job is to absorb impact. That's job one. Job two is to allow for friction-free movement between those two bones. Allows them to slide on each other. And one of the little stats I mentioned last time was two bones with hyaline cartilage and synovial fluid sliding on each other. The coefficient of friction, or basically the slipperiness of that, is 5 to 20 times higher than ice sliding on ice. So your bones slide on each other really, really well under ideal circumstances. So that's your articular cartilage. And so that's the blue stuff on this diagram here, lining our generic joint. That's our articular cartilage. There's a joint cavity. So there's space between the two bones, and that's what allows for that movement, the gap. And there's a joint capsule, and the joint capsule has two layers. So there's a superficial layer, so again, close to the skin surface, that is a fibrous layer. And so the fibrous layer of the joint capsule is responsible for maintaining the integrity of the joint. So it is dense, irregular connective tissue. And so remember from last time that means collagen fiber is running in every which direction. And so that protects the joint against a variety of stresses, whether it's rotational, traction, well, not compression, but rotational or traction stresses. Okay, so that's important about it. So that's, I don't know, I backed up one, sorry. Oh, no, it didn't, never mind. So that's the fibrous layer. That is, so we talked about the static stabilizers in the case of the shoulder joint or the glenohumeral joint. So the joint capsule is a static stabilizer. It determines end range of motion, keeps the two bones from sliding apart. The synovial membrane, on the other hand, is deeper, so it's underneath the fibrous layer. And so its job is to secrete synovial fluid. And synovial fluid is primarily a lubricating fluid, helps those two bones slide on each other. But another important thing about synovial fluid is that it helps nourish, if you will, the chondrocytes. So remember that in general, cartilage is avascular, meaning it has no blood supply. But those cells, because they're alive, still need proteins, they still need oxygen, they still need to get rid of their waste products and all of those things. So if our articular cartilage, so in here, if that doesn't have blood supply, the way that it gets those things is through diffusion from capillaries in the joint capsule. So oxygen will diffuse from here, amino acids, your protein building blocks, glucose, etc. They'll diffuse into the synovial fluid, and then as we move the joint around, that's going to push some of those things into those chondrocytes. So that's how they get access to all the things that they need through the synovial fluid. So synovial fluid lubricates, but it also nourishes the structures inside of the joint. So you have ligaments inside the joint, some joints as well. So like your anterior cruciate ligament, your ACL, is an intracapsular ligament. And so in order for it to get some of its nourishment, it can use the synovial fluid. Yep?
So when they say like you rupture your bursa sac, does that mean like the joint capsule like pops and the synovial fluid runs out?
Ah, that's a good question. Give me 10 minutes, and if I haven't answered it, then remind me. But yeah, it's a really good question. So there's our capsule. Oh, and that was the other thing I was going to show you really quickly. So if you use the anatomy app thing, so this is layer 3 if you're playing with the layers. So this is layer 3 of connective tissue. So here is his shoulder joint capsule. Let me zoom in a little bit on his right shoulder. Okay, so that's the fibrous layer there. And then if I take that off, you're going to see the glenohumeral ligaments. So we'll hide that. So there's our superior, middle, and inferior glenohumeral ligaments. So we'll hide them. And then I'm going to hide the coracohumeral ligament here. Okay, so then that's your synovial membrane. So again, deep to the fibrous layer, deep to some of those capsular ligaments. So that's what that looks like if you want to find it on the anatomy app. All right. And then ligaments. So a bit about the ligaments. So there's 3 different categories of ligaments. So ligaments can either be capsular ligaments, which means basically they're just a thick part of the capsule. So there are parts of the capsule that have additional collagen, that have additional fibers, if you will. And so sometimes anatomists name those and say, hey, that's a separate ligament. So for example, the superior, middle, and inferior glenohumeral ligaments are oftentimes referred to as capsular ligaments, as being just thick parts of the fibrous layer of the capsule. So capsular ligaments, thick parts of the capsule. Extracapsular ligaments, anything extra, is outside of. So they are ligaments that are part of the joint, give it its structural integrity, but they're outside of the joint. And then intracapsular ligaments are inside of the joint capsule. And I'll show you some examples of those here in a second. All right, and then last thing, nerves and blood vessels. So the joint capsules themselves, particularly the fibrous layer, is really important for knowing where we are in space. So if you flex at the shoulder, you know where your arm is in space based on feedback that you get from special sensory organs in the muscle, but you also have special sensory organs inside of the joint capsule that tell you that one side of the joint's compressed, the other side is not, and so the brain's able to interpret that as the glenohumeral joint's in flexion right now. So those nerves are really important for knowing where we are in space. And then blood vessels, as mentioned, helps provide oxygen, amino acids, those kinds of things to the fibroblasts in the fibrous layer of the capsule, but also, again, they diffuse into the synovial fluid to nourish the chondrocytes inside of the joint as well. All right, so in terms of different types of ligaments, so capsular ligaments I mentioned, so this is on your right side. So this is a view of the right shoulder from the anterior aspect. So those are the collectively superior, middle, and inferior glenohumeral ligaments. And so again, those are sometimes referred to as capsular ligaments, as being just thick parts of the capsule. On the left side, you have an anterior view, a front view of the right knee, but we've taken off the patella, which is your kneecap. So you can see an extracapsular ligament here. So the LCL, your lateral collateral ligament, is a ligament that protects the knee from a varus force, from a force pushing from the inside out, or medial to lateral. And that's entirely outside of the knee joint capsule. So it's one that you can palpate or you can feel if you cross one leg over the other. On the outside of your knee, there's a little cord out there, and that's your LCL. Yep.
So I was just going to ask, what happens if they have lateral ligaments?
Yeah, that one's relatively unusual, but basically the knee kind of buckles laterally on them. one of the larger problems with that is you actually have a nerve that runs right behind it, and so then when the knee buckles, they get like a zinging pain down in their foot, and so that tends to be the more irritating thing for most people. Yep. I might get a chance to show you some video. There's some pretty gross videos of guys hurting that in football, so maybe we'll have time. And then intercapsular ligaments, so your ACL, the anterior cruciate ligament, this guy, so the big one in the knee, that is entirely inside of the joint. So one of the reasons that matters, that affects ACL, the ACL's ability to repair itself, because the ACL, when it tears, let's say it's referred to as a mid-substance tear, meaning it's right in the middle of the ligament. So if the ACL tears in here, there will be some clots that will attach to the ends of the ACL, and they're going to try to kind of bridge that gap between the two pieces, right? So it's going to try to heal itself. But the problem is every time you flex and extend the joint, you're going to squish that synovial fluid around, and so that's going to knock those clots off, and so the ACL is never able to repair itself because of that, right? So because of that location, that affects its healing capacity. So then that's why you have to get it repaired surgically if you want it fixed. So that's an intracapsular ligament. The other interesting thing about that, if you've ever seen anybody after an ACL sprain or you've done it yourself, you know that within 24 to 48 hours, their knee just explodes, right? Just balloons up with a massive amount of swelling. And so what happens then is that damage to the tissue inside of the joint causes a bunch of fluid to migrate inside of the joint, and so that's what causes that really significant swelling that we see with ACL injuries. All right, a little case study for you to break things up a bit. So what I've got for you is you're going to pretend that you are a physician. Let's go with that. You're an orthopedist. And you have a patient that comes into your clinic. He is a 35-year-old male, and he is recreationally active. He, for the most part, runs. So he runs 5 or 6 days a week, probably about 25, 30 miles. And he tells you that he has been really limited in his running, particularly for the last year, because of progressively worsening hip pain. So he's had hip pain going on for about 5 years. And it's gotten just worse and worse. Initially, it started out as what he describes as groin tightness. So it'd be like after he goes for a run, he's got tightness in his groin. But it has progressed to, it hurts when he stands for prolonged periods of time. So like more than 45 minutes, he has to sit down. If he goes for a run, it doesn't usually hurt during the run, but afterwards, the pain is bad enough that he has to sit down for a long period of time, like can't get up and walk around for a while afterwards. Has trouble walking the dog. Can't make it through a 3/4 of a mile loop without sitting down. And so he's come to see you because it's now started to interfere with his activities of daily living. It's become problematic. Other things, so basically it started as groin pain. It's kind of medial and then anterior some of the time. And then, and this is a key symptom, whenever you have the patient lie on his back and then you passively flex the hip, so you push it up into being bent like this, and then you adduct it, so you move the leg toward the midline, and then internally rotate the hip, so you take the front of the humerus and rotate it toward the midline. That is exceptionally painful. All right, so any guess what might be going on that's caused his progressively worsening hip pain over the last 5 years? Yep.
Breakdown in the cartilaginous hip, which is inflaming his joint.
Yeah, he's got osteoarthritis. So yes, that's what's going on there. So this particular patient has osteoarthritis, which is a wearing away of the hyaline cartilage, or the articular cartilage inside of the joint. And so this particular case is a little bit more complicated in that this patient has what's referred to as hip impingement. And hip impingement is like one of the, and for the last 5 to 10 years, has been one of the really hot topics in sports medicine. You hear athletes all the time that have like hip or groin pain. They go to the doctor, they come back, they're like, oh, I got hip impingement. And so it's, like I said, super popular. Used to, when you go to sports medicine conferences, the hip section, like if you go to a lecture on, there would be like a lecture on the elbow and one on the hip. Nobody went to the hip. Now, the hip lectures are like standing room only, and nobody really cares about the elbow. So hip impingement is one of the interesting hot topics in sports medicine. So this particular impingement that this individual has is what's called a cam impingement. So there's your normal hip joint, right? It's a ball and socket joint. You've got the acetabulum, which is the socket. Very similar structure that we talked about to the glenohumeral joint. So you got the head of the femur there, the neck, and one of the important things here is to notice that there's a pretty big drop-off between the head and the neck. So that's what allows for good range of motion in the hip joint. So whenever you flex the hip, for example, then this part of, my mouse will come back, then this part of the humeral head is going to slide into the joint, and then this neck here clears space for that. So now you're looking at the right hip. We've pulled off the femur. So this big ring here is called the lunate cartilage. That's that really thick, 7 millimeters thick, ring of cartilage inside of the hip. It's that hyaline cartilage that helps absorb impact. The hip also has a labrum, which probably can't see, but it's this little tan thing here. And that's a ring of fibrocartilage, just like the glenoid labrum, that helps deepen the joint, but also provides some proprioceptive feedback, which is information about where your hip is in space. And so this particular kind of impingement, so cam impingement, the one in the middle there, so you got the normal hip on the left, cam impingement in the middle. That's most common in men. Typically, they report pain kind of in their 20s or 30s. And so what happens with cam impingement is that you have an abnormal shape or an abnormal growth on the neck of the femur, big bump there. And why that matters is whenever they flex the hip, well, that big bump moves inside of the hip joint and puts a whole lot of pressure on this anterior superior aspect of the joint. And so if they are running and you're landing on the hip in flexion when you're running, or if they're doing a lot of lifting weights like squatting and deadlifting, when you're at the bottom of squats or deadlifts, that puts a whole lot of pressure on that one part of the hip socket. And so then what they end up doing is basically wearing down this part of the cartilage right there. And so if you wear that part of the cartilage away, then you've got exposed underlying bone, and that's going to cause significant pain. That's osteoarthritis there. So the arthritis, it's a little more complicated, is caused by a deformity in the hip. The one on the right there is called pincher impingement, as you can see, or pincer. And so that one's more common in women. Typically, they report pain sometime in their 30s. And so rather than having an abnormal shape to the femoral neck, you have a socket that's too deep. But the symptoms are basically the same. So when they sit for long periods of time, then they end up getting pain kind of in that anterior aspect of the hip, but then also in the groin. The interesting part about, or an interesting difference between cam and pincer, is because of the shape of the socket in pincer, is that you've got pressure on this anterior part of the femur that actually kind of pushes it down and back. And so in women with pincher impingement, again, mostly women, not exclusive to women, but more common in women, because it's forcing the femoral head down and back, they tend to have arthritis back here on the posterior and inferior aspect of the joint. So what can be done about that? So now that we know that our patient has worn down the cartilage on that aspect of the joint, and he's got a misshapen joint, what can we do? Guesses? You could do a hip replacement, but this patient's only 35, and so hip replacements can last 25 years or longer, but most of the people that last 25 years in are people that got it when they were like 65. And so if you got a 35-year-old, it may not last that long. You might have to have a revision. So we're trying to avoid that. Yep, what were you going to say, David? You could, yep. So that's one of the things that can be done. That's still fairly experimental. It's not a widespread therapy at this point. So the most common therapy at this point is to do what's called microfracture. And some of you are probably familiar with it. I know, like from sports all the time, I hear, oh, this guy's out. He had to have microfracture surgery. So what they do with microfracture, back it up a little bit, is they actually, so you'll have a wearing away of cartilage in this area, and so they'll go through and actually clean up the edges of that, and then they'll use a drill. It's not exactly a drill, but it's a small little pointed tool. And basically they'll tap into the bone, and they'll try to expose this underlying layer of spongy bone or trabecular bone. And so in that layer of spongy bone, or intermixed in there, you have stem cells. And so you've got stem cells that are capable of differentiating into osteocytes, which are fully mature bone cells, or chondrocytes, the cartilage cells we talked about last time. And so if you drill a bunch of little holes here, you allow those stem cells to migrate out of the inside of the bone to that site, and then they'll form a clot, they'll differentiate into chondrocytes, and they'll lay down some new cartilage. The replacement cartilage isn't quite as good as the original, but it is pretty good, and the idea is to avoid, as long as possible, hopefully for at least another 10 years, push back the clock on a joint replacement. So that's the idea behind that. Now, the downside is it takes a pretty long time for that cartilage to regrow, so they end up on crutches for like 6 or 8 weeks, which sucks. So that's kind of the downside to that. As opposed to if they get a hip replacement, like they're walking that day. So there's a little faster progression there, but again, it's not your own hip. So, and then the other thing they do, so this is again pretty common in, as part of that, is they'll go through and actually reshape the femur. So they'll actually take off part of that bone and then repair the labrum as well. All right, so other stuff. in synovial joints. So some synovial joints have, not inside the joint capsule itself, but around them, they'll have fat pads. So for example, in the knee, so on the anterior inferior aspect of the knee, just behind your patellar tendon, you have a fat pad. So those cushion impact. It's kind of one of their job, or their primary job. They also just fill in space. There's also a fat pad just in front of or anterior to your Achilles tendon. There's some fat that takes up that gap there. So behind your ankle joint, there's another fat pad. So some joints have fat pads near them, some don't. Some joints have articular discs known as menisci. So for example, the knee joint has medial and lateral meniscus, and we'll talk about those quite a bit when we get to the knee. The sternoclavicular joint, interestingly, has a meniscus to it. So some joints have that, some don't. But again, that's just basically like not necessarily a ring, but a wedge of fibrocartilage inside of the joint is a meniscus or an articular disc. Bursa, so what bursa are basically little synovial membranes, but just tiny little sacs. So they're not part of the actual joint, they're just a synovial sac adjacent to the joint. And they help structures kind of roll and slide on each other nicely. So for example, we talked about impingement or subacromial impingement in the shoulder. And so one of the structures that can get impinged is that subacromial bursa. So you have a little bursa, and that's the thing that's pictured here. You have the subacromial bursa underneath the acromion between it and the humeral head. And so as you abduct the arm, it helps to allow for that nice sliding motion between the humerus and the acromion. And it allows for movement of, specifically, of the supraspinatus muscle. It keeps it from dragging as much as possible on the acromion. So those are bursa. And then tendon sheaths. Tendon sheaths are essentially specialized bursa that wrap around parts of tendons in really high friction areas. So I'll show you a picture of those here in a second. All right. So bursa are not only like around the joints and helping muscles move on each other, but you also have bursa underneath your skin in certain areas. So for example, this guy has an acute or traumatic bursitis of his olecranon bursa. So you actually have a bursa that sits underneath your skin on your olecranon that as you flex the elbow helps the skin slide across that olecranon, keeps it from dragging and keeps it from tearing. And then sometimes if you like land straight on your elbow, so you see it in football, like running backs or receivers a lot when they're holding the ball and they can't catch themselves and they land on their elbow, then that bursa will just blow up. And so that's what this guy has done, is fallen on his elbow. Goes away on its own. You can compress it, you can ice it, like you can just put a wrap around it and then ice it as well. Or they can just drain it, like they can aspirate it. Oftentimes when you do that though, it comes back. So typically we just do compression and ice, anti-inflammatories. On the right side there, so two of the thumb tendons that we talked about last time. So anybody know what muscles these are? I'll be super impressed. So you got extensor pollicis brevis and then the abductor pollicis longus are those two muscles. So those two muscles have a synovial sheath around each of them. You've got this retinaculum here that holds them down. And so those muscles have to slide under that retinaculum, so they have a little synovial membrane that allows them to do that. The long head of biceps tendon has a synovial sheath around it as well. So sometimes biceps, rather than getting like a tendinitis, gets what's called a tenosynovitis. You get an inflammation of the synovial sheath. It doesn't affect the treatment. It doesn't really matter what it is. You treat it the same way. But there's a fat pad in the knee joint, the one that's, again, just underneath the patellar tendon. And then there's a traumatic bursitis. So one of the other ones that tends to blow up is the prepatellar bursa. So it's just on top of the kneecap. Serves the same function as the olecranon bursa. It's just gross looking. Sometimes people like, for example, in my previous school, we had a basketball player like landed really hard on his knee at a morning practice. And he came back in the afternoon and his knee looked like that and he was freaking out. And so it's like, oh, it's just a bursa. Like, it looks gross, but it's not that big of a deal. So he had a compression sleeve and he was fine. All right, so factors that influence the stability of joints. So number one is the shape of the articular surface. So the more bony overlap there is between the two surfaces, then the more stable the joint is. So for example, think about something like the glenohumeral joint, where there's not a lot of bony overlap between the glenoid cavity or glenoid fossa and the humeral head, as opposed to, we'll stick with the same kind of joint, the hip joint, the acetabulo-femoral joint. There's a lot more overlap between the two, so the hip's much more stable than the shoulder, even though they're the same type of joint. So the shapes of the surface matter for stability. Ligament number and location. So based on the arrangement of the ligaments determines which motions are potentially problematic or are the most likely to cause dislocations of the joint. So for example, in the hip, you have 3 primary hip ligaments that we'll talk about later, but collectively, those 3 primary stabilizers of the hip are not very good at limiting hip flexion, adduction, or internal rotation. And so the most common way to dislocate your hip is to, or to have a traumatic dislocation, is to load the hip with it in a combination of flexion, adduction, internal rotation. So typically a contact injury, somebody like jumps on you or pulls you down in that position, and that can overload the rest of the joint capsule, and so then you can dislocate the hip. And then last one, there's muscle tone. So as muscles get stronger, their tone increases. You also thicken the tendons. And so because of both of those things, stronger muscles make for more stable joints. Yep.
So is it true that because like Bo Jackson dislocated his hip, everybody says it's because he was like so powerful?
Yeah.
He was running and got jumped on, that's why he dislocated, or is it just because it was like a weird circumstance?
I think it's more weird circumstance. It was just like he was in a bad position and he had enough force and that was it. I've seen people talk about that like with Saquon Barkley too, with his ACL injury. They're like, oh, he's just too strong. And it was like, I don't know about that. I mean, certainly, you know, if there's an imbalance between your quads and your hamstrings, that can be a factor in ACL tears specific to Saquon. But I don't think it's an issue of like he's just too strong. I don't think that's a good way to describe that injury. But yeah, same with Bo. Yeah, I think that's bad luck.
Like the same thing with Derek Rose, right? We say his quads are much stronger than his hamstrings, that's why he's torn his ACL, something like that.
Yeah, and you tend to see that in soccer players too, just from the nature of soccer where it's such a quad-dominant game that they have to really be deliberate about working on their hamstrings, otherwise they can really predispose themselves to ACL tears. All right, so I'll tell you a really abbreviated version of this story because I know I'm getting close to my time for the day. So I've mentioned before, coaches didn't want their athletes to lift weights, certainly into the 1960s, because they thought that it would be bad for the athletes, that it would make them too big, too slow, and limit their range of motion. And so this is an anonymous Big Ten coach from 1956, but you can see that he doesn't want any muscle-bound weightlifters on his team. And that really started to change. You get a guy named Al Roy. And Al Roy, the short version on him is that he was in the Army during World War II, and while he was with the Army, he actually got assigned to work with the U.S. weightlifting team, the Olympic weightlifting team, and so he got to see how big and powerful those athletes were. And so the idea that lifting weights would make you slow made no sense to him. So for example, one of the guys, the heavyweight on the U.S. Olympic weightlifting team on the time was a guy named John Davis. And John Davis could do a full standing backflip with a 45-pound dumbbell in each hand, right? And so if you've got a guy that can do that, somebody being like, lifting weights is going to make you slow, it's pretty hard to believe. And so when Al Roy came back to the U.S., he was from Baton Rouge, Louisiana originally. And so he's like, we should get these athletes lifting weights. Like, I really think that would be helpful for them. And he ended up opening up his own gym. And so he goes to his old high school. And they have just lost 1954. They lost their last game of the season to their crosstown rival, and that kept them out of the playoffs. And so Al Roy goes to the coach and says, look, I know you're in danger of being fired if you don't turn it around next season. What do you got to lose? Why don't we try lifting weights? And so he had the players lift weights starting in January of 1955. They lifted 3 days a week starting in January all the way up until when the season started in August. By the time the season started, every player on the team had gained at least 9 pounds. The starting running back, who would go on to win the Heisman at LSU, had gained 24 pounds over the course of that year. And then the starting tight end, I think, gained like 35 or something like that. So you've got this one team that's been lifting weights for 8 months, and everybody else they're playing has only been running miles and doing up downs or whatever you want to call them, where you run in place and fall on the ground and get up. So that's what they've been doing for conditioning. This team has been lifting weights. So as you would imagine, this team is Struma. So that's Billy Cannon, picture there doing deadlift, and that's Al Roy, the strength coach there on the right. So this team goes on undefeated through the high school season that year. They break all the records, the scoring records. They win the state championship game 40-6, the biggest margin of victory in any state championship game up to that point. And then Cannon goes to LSU, wins a Heisman. They win their first national championship with him as their running back. He's also a really good track athlete. He wins state in the 100, 200, and the shot put, which is an interesting combination of things. So he's a really powerful athlete. And so after that, a bunch of other coaches are like, maybe lifting weights isn't so bad. Because Al Roy, in addition to training LSU and training Billy Cannon at LSU, trained Jimmy Taylor, who was a Hall of Famer that played for the Packers here in the 1960s under Lombardi. And Al Roy goes on to the NFL, or at the time the AFL, works with the Chargers, eventually working with the Chiefs, the Cowboys, etc. Now later in his career, like when he's working with the Chargers, Dianabol has been invented by that time, and some of the players have talked about how they had to take pink pills with their breakfast. But when Roy was working with both LSU and the high school team in Estruma, they couldn't have been using steroids because they weren't invented yet. So there's that. So that is just one team lifting weights and nobody else doing it. Why does that matter for now? The coach at the end of the season, Big Fuzzy Brown, it's a great name, at the end of the season, when they asked him about to look back on the weight program and all of that, he didn't talk about how much bigger the players were, how much faster they were. He talked about they didn't have any shoulder dislocations and they didn't have any knee injuries. And that was the biggest thing, was that nobody missed time because their joints were more stable, tying it back to what we were just talking about, because of the weight program. They just didn't have the injuries that they'd had in the past. And so for him, that was the biggest differentiator, not the fact that his players are so much bigger, faster, and stronger. So we do get adaptations in those connective tissues, so in the tendons and in the ligaments around a joint, in response to strength training or sprint training. So if you're doing running really fast, that's anaerobic training, so that counts too. So strength training or anaerobic sprint training results in an increased number of collagen fibrils. So remember we showed you those on the anatomy app last time, so you have more collagen fibers. Not only do you have more of them, but the ones that you have then are larger. So more fibers, they're larger, and they're increasingly cross-linked to each other. So what you have then is a much stronger ligament, and the same thing happens in the tendons. So when you lift weights, the muscles can pull harder, right? They pull harder on the bone, and so that causes an adaptation in the tendons. Basically, that tensile stress stimulates the fibroblasts to lay down more collagen, so you get stronger tendons. And then you also get a stronger bone, certainly at the insertion point where that muscle inserts. You get a thickening of the outer layer of the bone, the periosteum. And so the bottom thing on there is that the degree of adaptation depends on intensity. The heavier you lift, the faster you run, the more of an adaptation you're going to get. So I think I mentioned previously at some point, we talked about the idea of doing blood flow restriction training, where you cut off blood flow to a limb and then you exercise the muscle to induce metabolic stress, and that can cause the muscle to grow. Certainly it can, but you're not really loading the tendons or the ligaments there, and so you're not going to see the same connective tissue adaptations with that lightweight metabolic training that you're going to see with just heavy lifting weights and running really fast. So not only do the muscles adapt to strength training, but as you know, the bones do, but in addition to that, the tendons and the ligaments do as well. So you get more stable joints in response to the training. All right, and so then we're going to talk about the different types of synovial joints, and the types are based on the shape. And so again, based on the shape of the joint surfaces, determines what it is that joint's able to do. So in how many planes does it move? Yeah, that's the big one. So the degrees of freedom are determined largely by the shape of the joint. So the first one is a plane joint, which is where the bones just kind of slide on each other. All right, so we'll get to those. All right, so the first one there is a plane joint. And so plane joints, you got two bones that just kind of slide on each other, but there's no rolling or spinning. And so we see that in this case in the intercarpal joints. So remember you got 8 carpal bones, so between those carpal bones you get a little bit of sliding. One of the things I talked about a little bit with the radiocarpal joint was the mid-carpal joint. So the joint between the proximal and distal row of carpal bones, that mid-carpal joint is one of these sliding joints. So you just get some sliding between the two bones. So it's usually not really counted as osteokinematic motion because it's not a really big obvious motion. It's just one of those arthrokinematic motions by itself. So those are your plane joints. Two bones just slide on each other. Hinge joint. So you can see there that you have a cylinder and a trough. And so the primary example of a hinge joint is the humeral-ulnar joint, that primary hinge joint of the elbow they talked about. So the cylinder is the trochlea, the trough is the trochlear notch, and so the trochlear notch wraps around the trochlea, makes for a fairly stable joint, and it only allows for 1 degree of freedom. So some of the questions in the quiz bank and in the test bank are about how many degrees of freedom different joints have. So, or what type of joint it is. So one of the questions is about the humeral ulnar joint. So know that it is a hinge joint that only has 1 degree of freedom. Other hinge joints, so like your knee is more or less a hinge joint, although it does get some rotation. Your IP joints of your fingers are definitely hinge joints because all you get is flexion extension. But you don't get quite as much bony overlap between them. Then we got our pivot joints. So you can see there with a pivot, you got a sleeve and an axis. Anybody remember what the sleeve, that name of that ligament is in the elbow? Starts with an A, if that helps. It's the annular ligament. So the annular ligament is the one that wraps around the radial head, keeps it attached to the ulna. And so that then serves the purpose of being the sleeve. And so then you get just rotation at that joint. So the proximal radial ulnar joint is a pivot joint. All you get there is pronation, supination, occurs in the transverse plane or horizontal plane, and that is all. So that's uniaxial movement there. Then condylar joints. So you have 2 oval or kind of egg-shaped surfaces. One's concave, so the concave one is definitely egg-shaped, and then you have a corresponding, sorry, the egg shape is the convex surface. So one is the convex egg shape, and the other one is a concave surface that corresponds to that. So the metacarpophalangeal joints of digits 2 through 5, your MCPs. So the distal aspect or the heads of the metacarpals are that convex surface. And then the proximal aspect of the proximal phalanx is the concave surface. And so because of the shape of that joint, then you get 2-plane motion or biaxial motion. So you get, in that case, flexion extension and then AB adduction. And then saddle joint. So the primary saddle joint used in every anatomy class is the carpometacarpal or CMC joint of the thumb. And so it looks like two horse saddles on each other. Remember, each surface then has a concave and convex aspect. And so because of that, you get 2-plane motion. So in the thumb, or at the carpometacarpal joint of the thumb, you get extension and flexion, and then abduction and adduction. So those occur at the carpometacarpal joint. The only other saddle joint I'm aware of, the sternoclavicular joint is sometimes described as being a saddle joint. But other than those 2, I don't know of any more. So biaxial movement there. And then the last one, ball and socket, 2 examples. The glenohumeral joint, as we've talked about, and then the acetabulo-femoral or hip joint. And again, the key differentiator between the 2 is the amount of bony overlap in the hip that we don't see in the shoulder. So then that affects stability. All right. And then last thing, just because I don't know how many of you have ever seen a joint replacement, but this is what a hip joint replacement looks like. There's a stem, and so basically what they do is they'll go through and actually cut off the neck and head of your femur if you have to get a joint replacement. And then they'll drill and put this stem down into the medullary cavity. And they actually have to like hammer it into place. And the reason I mention this is when I was first getting into like sports medicine, in my mind, medicine was always like really precise and scientific and all of these things, and certainly it is. But at the same time, things like orthopedics, that's basically carpentry class. And so whenever I had to go, whenever I was in grad school to be an athletic trainer, we had to go observe surgeries, and I had to go watch knee replacement surgery. And so what they do in knee replacement is kind of like they do in hip replacement, where they basically cut a T shape into the end of your femur, and then kind of a T shape into your tibia, and then they put this plate on there, and they have to hammer it into place, right? And so I'm sitting there watching this surgery and watching this physician just like hammering this thing into this guy's femur. I was like, I felt like it would be a lot more scientific than it is than with your big mallet there. But that is how it works. So effectively what you do, most of the time, joint replacement is due to osteoarthritis, like 93% of the time. And so once those surfaces get so worn down and painful that you just can't sit, can't do your activities of daily living, then people get them replaced. And so you get it replaced with metal or ceramics. In the case of the hip, so there's a little socket that fits into the hip, and then as you can see here, they actually, most of the time, they drill it into the pelvis. There's a cement that they can use, but most of the surgeries in the US don't use it, like maybe a third of them actually use a cement. So for the most part, they'll screw it in there, and then this part of the femoral stem, you can kind of see it has sort of an odd texturing to it. And so the idea there is that it encourages the bone to grow around it rather than having to cement it in place. You get the bone that will grow around it and keep it in place. So that's what joint replacements look like. And I'm out of time. So tomorrow in lab, we're going to go over all the bones and muscles, kind of as a review. And then remember, on Friday, we're going to do Jeopardy. So if you want to come on Friday and play Jeopardy, we'll do that. And I'll post a recording of it after class. Yep. That one? Yep. Sure. So, oh, sure. So we'll see y'all tomorrow and or Friday.